I want to slow things down and talk about heart health in a way that most people don't usually hear it explained. Not in terms of prescriptions, not in terms of panic, and not in the terms of waiting for symptoms, but in terms of understanding what's actually happening inside the arteries and why modern cardiovascular screening exists in the first place. Let's start with something very basic: plaque. When we talk about heart disease, we're really talking about its plaque building inside the blood vessels. Plaque is not just cholesterol floating around in your blood. Plaque is a mixture of cholesterol, inflammatory cells, calcium, scar tissue that slowly builds up inside the artery wall over years and decades. Most of the time, this process is completely silent. You don't feel it happening. You don't get chest pain. You don't get shortness of breath while it's progressing. That's why heart disease often catches people by surprise. We know all this. But here's an important point that gets missed a lot. Not all plaque is the same. Some plaque is soft and early. Some plaque is older, more stable, and calcified, which is calcium's deposited. And some plaque is more dangerous because it's inflamed and prone to breaking down. This is where our modern imaging tools come. A calcium score or CT calcium score looks for calcium inside the coronary arteries. Calcium doesn't appear early. It appears later, after plaque has been there for a while and has healed and hardened. A cardiologist that is often referenced in this context is Dr. Ethan Weiss, who explains it nicely to patients. He says that a calcium scan is like a satellite image of your heart. It doesn't show every detail, but it shows evidence of past injury over your lifetime. The more calcium we see, the more plaque we know exists. And the more plaque someone has, the higher their long-term risk of heart attack and cardiovascular death. The relationship is very strong in the evidence. Now, let me be very clear about something. This is not about rushing everyone onto statin. An abnormal cholesterol test is not an automatic prescription. A calcium scan is not a medication mandate. When I see an abnormal lipid results, I don't see a failure. I see a checkpoint, a moment to pause and ask what's actually happening in the arteries. Sometimes the answer is not a lot. But if someone has abnormal lipids, even if it's mild, a calcium score of 0, a healthy blood pressure, good metabolic health, doesn't smoke, and is physically active, that's a different situation from someone who has the same cholesterol but clear plaque in their artery. So context matters. Medications like statins work best when they're used for the right reason. They reduce risk by stabilizing plaque and lowering the chance of plaque rupture. If there's no plaque or very low lifetime risks, the conversation is different. That nuance was not always present in the older approaches to heart disease. For many years, cardiovascular medicine was number driven. Cholesterol above a certain level means treatment, age above a certain number means treatment. Risk calculators were applied broadly, often without seeing what was actually happening inside the arteries. That's actually changing. A lot of doctors, particularly one that I follow quite a bit, like Dr. Peter Attia, have developed reframing tactics to help discussion about lifetime risk, plaque burden, early prevention, not just short-time event reduction. We're slowly moving away from this dogma and towards individualized risk assessment. Now let's talk about screening. One of the biggest mistakes people make is thinking heart screening is something you do after symptoms start. Chest pain, shortness of breath, collapse. You probably know this already. By the time those appear, disease has often been there for many years. Modern screening tools, calcium scans, and in selected cases, CT coronary angiography, is about establishing baselines early. Not every 30-year-old needs a scan, and not every person needs advanced imaging. But if you're in your 40s or 50s, have risk factors, family history, metabolic issues, unexplained symptoms, these tools can be incredibly helpful. Now, this is how I explain to my patients. If we check your heart and your calcium score is 0, your vessels look good, and your risk factors are controlled, that's not something to worry about. That's something to bank. We don't chase it every year. We recheck it 5, 7, 10 years. Now, there's another benefit people don't think about. If you've had this done and you wake up at 3 a.m. with chest pain 6 months after, You can go to the emergency and see a doctor and say, my heart has already been checked, I have a baseline. Now that doesn't mean that you ignore these symptoms, but it changes the entire clinical conversation. It reduces uncertainty, unnecessary fear, and sometimes unnecessary testing. Now I want to speak also to women and heart disease, because this is an area where we have historically done a poor job. Heart disease is still one of the leading causes of death in women worldwide, yet women's symptoms are more likely to be dismissed, minimized, or attributed to anxiety, reflux, or stress, especially if they're younger. And I'm sorry about this, but there's strong evidence that shows that women's cardiovascular complaints are less likely to be investigated aggressively, and that reassurance is sometimes given incorrectly. Women often present differently. They may not get classic crushing chest pain. They won't present with classic symptoms. They may get fatigue. They may get breathlessness. They may get jaw pain or vague discomfort. That does not make their risk any lower. So whether you're a woman in your 40s with risk factors or a woman later in life who's been doing everything right, cardiovascular screening still matters. Plaque does not respect reassurance. Message is for young and old. Young people, don't assume youth equals protection. Early plaque matters because it determines lifetime risk. Older people, don't assume symptoms are inevitable. A 0 calcium score in life can be very reassuring, feeding us away from unnecessary treatment. And for everyone, heart disease remains one of the biggest causes of illness and death worldwide. Despite all our advances, atherosclerotic disease still drives enormous morbidity and mortality. The good news is this: we now have better tools, better understanding, and better strategies than what we did before. The goal is not to medicalize everyone. The goal is not to prescribe first and ask questions later. The goal here is to see the disease early, understand the risk properly, and act proportionally. Heart health is a long game, and the earlier we understand where you stand, the more options we have, and the less likely we're going to be caught off guard later. That's the real value of modern cardiovascular screening. Thank you for watching FSD Doctor Talks episode on cardiovascular health. Please like, subscribe, and share. Thank you very much.